All right, so the last speaker of the day is Dr. Peter O Sullivan. And we have a little, we have named this lecture the Dr. Pamela Barton Memorial Lecture. It was established to honor Pamela Barton's legacy and recognize her outstanding contributions to advancing patient care and clinical education. She was a specialty physician in physical medicine and rehab, and a visionary in the field of chronic pain. She valued collaboration with interdisciplinary teams and pain advocate. She was a very big advocate for pain education. So she would be pretty pleased with this conference for doing exactly that. So it's my honor to introduce the Dr. Pamela Barton Memorial Lecturer for this year, Dr. Peter O Sullivan. Peter is a thank you, not quite yet. John is, sorry, Peter is a distinguished professor at the School of Allied Health Sciences at Curtin University and a specialist musculoskeletal physiotherapist. He is internationally recognized as a leading clinician, researcher, educator in musculoskeletal pain disorders. He is well published. He's a sought after speaker. He also consults where he reviews disabling musculoskeletal pain disorders. It's getting late. Peter's passion is to bridge the gap between research and practice in order to empower clinicians to deliver person-centered care to people in pain. Peter, I'm very excited to hear your talk and thank you for joining us. It is super early in the morning for him, and I really appreciate you getting up early and joining us.
No worries. Nice to meet you all virtually. Well, hello from Perth, Western Australia, other end of the world. It's early-ish in the morning here. So my talk today is to really talk about some of our work around physiotherapy-led interventions for management of people with chronic low back pain, and particularly this intervention called cognitive functional therapy, which we've been involved in developing over a period of time. I want to start with a story. And this is a story of a woman who presented a couple of years ago. And she talks about...
Sam, I'm 43 and I'm a mum and a nurse, and I'm also a back pain sufferer, unfortunately. And my back pain journey started back when I was 15. I was at the top of my game in a rowing squad, and whilst I was doing my training, I just got a cold, which you push through because you don't want to let your team down. The cold turned into the flu, which again, I pushed through and was supported by my coach and team to push through. To the point where I got chronic fatigue and my body just took a massive halt. And I have been in pain, I guess, ever since. So we're talking almost 30 years of pain. Yeah. I saw the doctors and specialists that my parents recommended for me. A lot of it just included pain relief. So a lot of pain relieving medications and physios. At the time, the most common physio procedure was just that little site adjustment and a hot pack. And I would go in, I'd have that adjustment, and by the time I'd driven home in the car, I was back in pain. It was just a circle. I saw chiropractors, and again, the same thing. I would get an adjustment and then just go back to normal. I just got used to living with pain. It really just became part of my identity. Being told something like, you'll be in a wheelchair when you're 40, when at the time I was in my 20s, was terrifying. It was, take this really awful medication, which has loads of side effects, or you'll be in a wheelchair. They are your two options in life. I well up just thinking about it. I felt very disempowered, very confused and very scared. And when you're already in chronic pain, it just starts becoming a bit of a downward spiral. And I dare to say that I was probably depressed for a larger proportion of the time because of just being in pain and the worry, and it seemed like there was no end in sight. Learned to push through, to minimise my inner feelings and concerns. and to actually question my own inner thoughts. Like, I was put on antidepressants at an early age as a result, I guess to help me snap out of it. I was locked in. I avoided multiple activities that would have any chance of any risk of my body being in an unstable state. I would avoid. That would even involve pushing a shopping trolley around Coles. I wouldn't push a shopping trolley. I avoided activities with my kids. I didn't play soccer with them or play tennis, anything, because I lived in a state of fear that one foul move would just have this disastrous effects. And I'd been through so much, I didn't want to risk being through anything else. So I lived in a state of fear that things would get even worse. And I lived in a state of restriction, personally and with my family as well.
So, as you guys are all familiar with, this is a really common story around the world. We know that back pain is a leading cause of disability, has a massive impact on all aspects of a person's life. We just start thinking about diagnostic labels. Sam was given these diagnostic labels of, disc degeneration, radiculopathy, Trochanteric-Burside pain syndrome. She had a view at the end of 27 years of seeking healthcare from all the messages that she had been given, that her hip and back structures were damaged, broken, unrepairable, untrustworthy, and weak. She had a belief that she'd be disabled on opioids and antidepressants the rest of her life. She'd given up hope. She'd lost trust in healthcare. So across that 30-year journey, she was off work at the end of this time. Her pain levels were severe. She was disabled. She was opioid dependent. She was depressed. She's frightened. She described herself as broken. She had lost trust in healthcare and lost hope for any sense of recovery. So, of course, I don't need to tell you this, but in terms of low back pain, we have a small group with serious pathology, another small group where there is specific pathology, and then we have this much larger group. And unfortunately, people like Sam get put into this group where they have findings like degenerative change, which we know are very common in people without pain. They're a very poor predictor of future pain and disability, but they end up being given these diagnostic labels, which give them a sense of their body disintegrating, and very little hope for recovery. So obviously, contemporary understanding of pain tells us that it's complex and it's influenced by genetic factors. It emerges at different times of our life. We know that our cognitions around pain, our emotional responses to pain, our social environment, the kind of physical interactions, our lifestyle, and other comorbidities all influence changes at both the structural and motor system responses and complex changes through our nervous system that will influence our pain response and, most importantly, our levels of distress and disability. And so you start thinking of Sam's presentation around being told that she's damaged, the distress and fear and worry, the stress, financial stress of caring for young kids and not being able to interact with them. She had a job that she ended up not being able to do that was physically demanding. She stopped being active. She wasn't sleeping, and her whole health was compromised. Massive contributing factors that will drive both pain and disability. So we look at what the evidence tells us about what predicts low back pain. We know that its influence, or our risk factors, are influenced by contextual factors, past pain and stress events, mental and general health factors. But what we know is if you have an acute episode of back pain, if you start developing a negative mindset around your pain, and this is often fed by interactions with healthcare practitioners who are telling people their pain is caused by tissue damage, might have resulted from some kind of injury, that the consequences are disability, the timeline is uncertain, it may never get better, there are limited options. This starts to naturally create distress. And so, we start seeing the emergence of pain-related fear, distress, loss of valued activities resulting in depression, and then driving these unhelpful coping behaviors around avoiding, overprotecting the body. And of course, our health system has an abundance of passive therapies that doesn't put the patient in the driver's seat. And so the consequences in this cycle are often disability and pain persistence. And sadly, often our health systems reinforce these processes where we, in Sam's situation, these negative messages, unhelpful and passive coping strategies around treatment result in these negative emotional responses that just wind the system up. So we start looking at these behaviors around avoidance to control pain. Then typically we hear people say, I avoided to control pain, partly because I was told to by healthcare practitioners. But the more I avoided, the more disabled and frightened I became. I didn't know what else to do. And then we've been involved in a lot of work around the body response to pain and identifying that there are these both subconscious and conscious responses around when we're in pain and we're frightened, we clench our muscles around our body. We feel stiff and tense, we can't relax. But also this is reinforced by messages from healthcare practitioners to sit tall, brace the core, be careful with your back, lift with a straight back and bent knees. This idea that we have to protect this vulnerable back. And there's growing evidence that certainly people with low back pain move differently than people with pain. They move slower, they're stiffer, they can't relax, they overcontract and clench the muscles around their back and are unable to relax them. So there's a lot of evidence around the lived experience of persistent low back pain. That often pain began at a time when the person was under stress. They might have had an injury or might have been an insidious onset, often related to fatigue, other social stresses. But often the experiences of healthcare are overwhelmingly negative, where they get given negative messages about their body, often linked to imaging. There are often these passive treatments that are ineffective. The patients often feel unheard and dismissed. This leaves them feeling stuck in a situation where they're in pain, they're frightened, they feel tense, they feel weak, and they feel vulnerable, and their world gets smaller and smaller and smaller. So we start reflecting about what do patients with back pain want from us as clinicians? Well, number one, they want to be listened to. They want to be validated. They want to work in partnership. They want to know what's going on. They want to understand. They want a diagnosis if there is one, but they don't want scary diagnoses that don't leave them within any pathway to recovery. They want to know what the contributing factors are. They want to know what the future consequences are of their problem. And then they want a plan for recovery. They want control over their pain. They want functional restoration, and they want quality of life. So cognitive functional therapy was designed as a physiotherapy-led behavioral intervention to help people like Sam, who is in pain, distressed, and disabled, to get back to living again, to kind of bridge the gap, to get back to the valued activities that she knows that she wants to do, but really has lost hope for. So in the first phase, we screen people, we look at their biopsychosocial profile. And in Sam's situation, her pain levels were very high. She was disabled. She wasn't sleeping. She was high level of tension, anxiety. High levels of depression. She had a belief that her pain would become persistent. She didn't think she should be able to do her job in 3 months' time. She believed that an onset of pain was a sign that she should stop and avoid the activity. And so when we start profiling her based on the interview and the physical examination, we see a profile of Sam's presentation where this is a lady who's really in a seriously bad situation. She's avoiding physical activity. Her sleep is disrupted. She's highly guarded and protective of her back. She's avoiding normal movement. She's deconditioned. She's off work because of her back. She doesn't believe she can get back to work. She's on her disability support. She's financially stressed. She's a single mom with 2 kids. She has a belief that her back is damaged because she's been told this based on her scans. She's developed a negative mindset around her body that there's no way of improving it. She's got very low pain self-efficacy, and she's pain vigilant. She's fearful, stressed, anxious, and depressed, highly sensitized to touch and to move. Yeah, she has degenerative changes on her scan, but this is a normal finding for someone of her age and is not a strong predictor of any future pain and disability. And her general health is poor. So ironically, the key contributing factors to Sam's presentation are not related to her diagnosis. They're related to often the messaging and the lack of support that she's had through her healthcare process. So cognitive functional therapy takes all this information and it starts mapping a plan for that person's recovery. There are three key elements to this. The first is we call making sense, where it takes all the biopsychosocial factors that are relevant to that person, and it tries to map them in a way that helps them make sense of the multidimensional nature of their problem. The second part is to build confidence back in the body, to take them back to activities that they perceive as dangerous and that they avoid, to build a sense of safety and control back into them, and then to generalize that so that they can get back to the things in life that they value. And the third element's around lifestyle change, to re-engage in activities based on their preference, teach them relaxation strategies, restoration of sleep. And of course, this is an individualized approach because these factors are different for each person, and they're very much linked to the person's valued goals. So if we look at the number of sessions, and I'll talk more about the research in a minute, but this is usually around 5 to 8 sessions over 12 weeks, and then booster sessions after that if required. So the approach, this is approach towards training people to self-manage their own condition. So from a making sense perspective, this is to take the story of someone like Sam and to understand the role of contextual factors, the role of negative advice around damaging beliefs that drive these fear responses and overprotection and avoidance that leaves the person disabled and distressed and sets up a vicious cycle. So in this process, we develop a personalized biopsychosocial understanding. We use the patient's narrative and their presentation to help them make sense of their pain. So it's not like a generic pain education program. We help them to understand that a lot of the beliefs that they're given through healthcare are actually not well-founded. And we provide them with resources of patient stories and helpful information to help them understand that often the contributing factors to pain are modifiable and things that they can have control over. And then look at new responses to pain, new ways of responding to pain instead of overprotecting and guarding the body, to re-engage, relax, and move the body again. And this is very driven around goal setting linked to their valued activities. So we start mapping a new way of thinking, a new positive mindset that pain is not an accurate measure of damage, that relaxing and moving and engaging the body and building confidence and getting back to the things in life that are important can help break that vicious cycle. The second aspect is we call exposure with control, and this is a graded exposure model, but different to a typical graded exposure model. It really looks at the protective behaviors that the person has developed. And so this is a behavioral learning approach where the person is taken back to the activities and movements that they might have feared or avoided or are painful. They're reassured of their safety. And then they're taught to relax their body. We discourage protective behaviors or safety behaviors. We tell people that the human spine is designed to move, that it's safe to move the body in a normal, relaxed way. So we don't want them protecting their body when they engage with movement. And then we gradually get them back to valued activities that are painful, feared, or avoided without protection to build confidence back in the body. This behavioral learning approach seems particularly effective because it can really shift mindset. Person will often have a belief that to relax and move in a normal way without protection will make them worse, or actually usually they find it reduces their pain in the process. And then we generalize this learning into valued activities to get them to reduce their sense of threat, to build their sense of self-efficacy. We build strength and conditioning where it's indicated, and we chase their goals, getting back to work, playing with the kids, back to living again. And then the third element is around lifestyle change. So helping people to re-engage in physical levels of physical activity based on their preference. And of course, this is graded activity for people who are very deconditioned, addressing unhelpful sleep habits, teaching them relaxation techniques to respond to pain differently rather than overprotecting. Pain exacerbation plans are really important. Often we see people improve and they'll have an exacerbation and they freak out. But we see them as really powerful opportunities to change both their emotional and behavioral responses to pain. We identify the triggers, we identify the old responses, which in Sam's situation would be to clench up and panic and avoid movement, to realize that actually the new response would be to relax and move and engage with movement is a powerful way of responding. And of course, we're on call if that self-management plan is not working. So the qualitative data we've used to explore the patient's experience of this journey, and they kind of mapped it like this. This is a co-designed infographic of a bunch of people who've been through this intervention. And they talked about the fact that they'd been through this really tough journey, but they brought their story, a sense of hope and courage and a desire to partnership to this process. And then the clinician brought a sense of kindness and empathy and listening and partnership. So this idea of a partnership between the patient living with pain and the clinician to kind of map a path or a journey. Patients talked about the importance of their story being heard, that there was time and space for them to tell their story and it was heard and they were validated. There's a sense of reconnecting with the body, where they're vigilant to the pain, but really unaware of what their body's doing, of learning to relax the body and learning to move it without protection, where often these protective behaviors are completely subconscious to them. They talk about the importance of making sense of their pain, of understanding how their thoughts, emotions, their stress, their behaviors, and their body responses to pain can negatively impact on their pain. Then developing a sense of control and confidence to relax and move again, to get back to activities that are avoided for years, to re-engage in movement without protection. And then starting to develop healthy lifestyle factors of re-engaging in physical activity based on their preference, of getting more restorative sleep, of re-engaging socially, getting back to work. And then negotiating challenges and flare-ups were really important for them to feel like they had a partnership with the clinician who could really support them to teach them self-management strategies when they hit these pain flares. They then kind of describe this process of getting back to living, of learning to self-manage, of not relying on clinicians for pain relief, but actually having a sense of autonomy. And then they also described growth in other aspects of their life, a sense of that this wasn't just a journey about their pain, it was a journey about their life. And that started to influence their relationships with their family, with their friends, re-engaging in work and other areas of growth in their life. And at this point, the clinician was only required when self-management wasn't working. So we've done some qualitative work around this, and this is a paper published recently that kind of looked at this process of going from pain and protection to non-protection. And the qualitative experience was that these people often feel like they're in this protective state where they feel stiff and tense and they can't relax. And then this conscious state where they're actually being told to protect their body. They're sitting tall, they're guarding their back, they're careful when they move, they avoid flexing their spine. And then through this journey of a partnership with the clinician, they have this process of conscious non-protection, of they learn to relax and breathe and move and reconnect with their body. And then many of them describe this process of getting to a point of non-conscious non-protection where they're actually forgetting about their back. They're not vigilant about their body anymore or their back, and they're just getting back to living again. In terms of quantitative measures, we've observed this tracking a group of people with disabling low back pain, that where there is a relationship between movement and pain, then we tend to see as people improve, they have more range of movement, they're more relaxed with their movement, and they're faster with their movement. So we see these behavioral shifts in the way in which the person moves. And this kind of speaks to this embodied experience of pain, that we, pain is not just a thought, it's an embodied experience where our behaviors reflect how we feel about our body. So we listened to Sam's story here.
For us to take another step to try a new thing was really big for me. But I'm really happy to say it's actually been life-changing, and I'm so grateful. I'm sitting here today without crutches, not on opioid medication. It's actually that mind-body connection and seeing it as one system where if one part doesn't work, the other part doesn't function. I'm very used to the system of treatment where you need hands on your body to fix the problem. And it seemed very odd. And I'll be honest, concerning at the time that the clinician wasn't manipulating my body. And it took a while for the penny to drop, that I was actually going to be empowered to kind of fix my own body, which I never would have thought possible. The thinking differently was definitely the biggest thing for me, stopping that go-to panic station. And then the second point was doing differently, not doing the clenching, not doing the panic, not running straight to the drug cabinet and popping a tablet. I found the most interesting thing was for me in my body was when I'm experiencing an extreme bout of pain, certain parts of my body switch off and de-associate. So for me, my hips and lower back, as soon as I'm in pain, I lose the ability to feel and function, and my whole central cord just locks up like a rock. I've learned the power of my breath, which I never would have appreciated before. And I've learned how to get back to a stable homeostatic state where I can then get the flow happening again. I just would never have thought that was possible before. I hadn't appreciated how much I tensed and guarded and the impact that had on my progress. My old thinkings and habits of pushing through have actually been doing me more harm than good. My old thinkings and habits were push through, suck it up, don't complain. My breath work has really been key for me. And then that gentle movement, I guess, not needing to do things that are hard and fast and aggressive, just you can actually still get a lot of benefit with gentle, repetitive, controlled movements and building them up. Really good at going from 0 to 100. I'm really not great at going 10 to 20 to 30. So it's for me relearning the pathways that I need to do to get back to feeling good. I think in almost 30 years, I finally learned how to be at rest. I have spent so long fighting and pushing and just...
Whoops, sorry. I didn't mean to do that. I'm going to take you back to finish Sam's story.
Trust to take so long fighting and pushing and just edging my way through, I had forgotten how to stop and rest and really rest and recover. Since I've been doing this treatment, I've started getting my life back. I've started walking on the beach, on the sand, which is something I avoided for so long. My child loves nippers, and I'm now on the beach, going up and down the sand with her. I'm pushing a shopping trolley around the store. I might be doing it more mindfully, but I just have that inner courage now to try new things. I went walking on a reef the other day and looked for octopuses with my kids. I'm starting to plug back into life.
So Sam's story talks about this journey of getting back to living again. She said, I was given the time, compassion, honesty, and hope. I was seen as a person, not a patient, as a human, not a task. Under this guidance and my support, my body and mind have blossomed. So at the end of that time, she came off her opioids. She was back engaging with people. She was back engaging in movement. She had a sense of strength and confidence. She was back to work. She was able to play with the kids. So when Sam was asked, why did she get better? She described empathy, compassion, time, and trust from the clinician, understanding the trauma response and the body-mind connection, personalized rehabilitation plan, being coached to gain self-autonomy, the importance of actually learning tools to take control of her own destiny, and learning to manage these flare-ups. And then finally getting on with life, finding a passion, a hobby that will grow you. So we've been involved in a number of clinical trials of this approach. They're mainly small trials that have been tested in chronic low back pain populations against a variety of different interventions. And these are mainly smaller trials with only a few physiotherapists. We'd had no trials compared to usual care, and we'd had no economic evaluation up until that time. There's one trial I think might be of interest to you. It was a propensity match trial, and there's now a clinical trial that's has come from this as well. This was in a pain clinic in Denmark, with people with very severe persistent low back pain. And this compared CFT to a multi-disc pain management program. And the interesting thing was around, this involved 8 consultations with the physiotherapist over 3 months. So these are people who are end stage, very disabled people. And compared to multidisciplinary pain management, CFT resulted in larger reductions in pain, disability, improved quality of life for 7% of the cost. So it's cheap. It's a very cheap intervention, which looks like it can be more effective in certain circumstances than often what are very intensive and more expensive interventions. I want to just talk to you now about the Restore trial. This was a clinical trial that was published in The Lancet this year. This was a multi-center trial conducted between Perth and Sydney. We took 18 physiotherapists and we trained them over 6 months to deliver this intervention. And the reason this is important is because we're literally training clinicians' behaviors to change the way they conceptualize pain, building different skills and mentoring them to work differently with people with pain. And so this training program involved training knowledge and skills, and then we worked with them, mentoring them while they treated people with chronic back pain within small groups. And we provided them direct feedback and reflection, and we coached them towards a competency standard. So we didn't let them into this trial until they demonstrated competency to deliver this intervention in the way that we thought was important. So that was a 6-month journey, and there's been a qualitative paper that has been published on this, where the clinicians talked about their own behavioral journey, their own change around changing their own mindset, their own clinical behaviors, around managing people differently, and building their own confidence and skills to deal with a patient's distress, of taking them back to re-engaging in feared and avoided movements and activities. And that was a really tough journey for the clinicians. We start looking at who was in the trial. We had about 500 people with chronic low back pain. We included anyone from 18 years over. So we included older people who are often excluded from clinical trials. People had pain for an average of around 4 years. We included more disabled people, were more disabled than most previous clinical trials around chronic back pain. We included people with health comorbidities, people post-surgery, people with mental health challenges. Many people, sadly, had given up on healthcare who came into this trial. So there were people who were just living in our community who were disabled, like Sam, who had just thought there was no other option for them. There were 3 arms to the study. We had the cognitive functional therapy arm only, which involved 7 treatments up to over 12 weeks. So the clinician could decide that. We had a single booster session at 6 months. We had a CFT arm with the addition of movement sensors, and these movement sensors provided feedback for the clinician and the patient to tell them, give them feedback around their movement, their range of movement, their speed of movement, to see, we use this to see if whether the addition of movement feedback was helpful as an adjunct to the intervention. The movement sensors also provided us feedback, so we could look to see whether movement was an important factor in terms of a shift in movement behaviors relative to their improvement as well. And we compared this to usual care. So we didn't put any restriction on care. And we saw that within this study, many people were seeing their general practitioner, taking medication. Others were getting hands-on therapies. And as I said earlier, a number of people had actually given up on care. So the primary outcome measure was pain-related activity limitation. And you can see here that the blue is the usual care group. They improved a little bit over the 12-month period, but there were significant reductions in pain-related activity limitation in both of the CFT arms. There was no benefit of the movement biofeedback over the CFT-only group. Now, these are large clinical effects, and the important thing here is that most clinical effects for interventions for back pain regress at 12 months. And what we found is actually the effect was sustained, actually improved at 12 months. So the idea of teaching self-management looks like it had taken hold in this group. So we look at clinically important difference of more than 5 points on a Rowland-Morris questionnaire. We saw 61% in the CFT group compared to 19% at 13 weeks, and this increased to up to 70% in the 12-month follow-up. We saw the same thing mirrored in the reductions in pain intensity. Again, we saw a slight reduction in pain intensity in the usual care arm, but larger and sustained reductions in the CFT arm. We saw, based on clinically important difference, over half or just around half of the people in the CFT arm reported clinically important reductions in pain versus those in the usual care arm. We saw these effects mirrored in terms of reductions in fear of movement, reductions in pain catastrophizing, and improvements in pain self-efficacy. And these are often important mediators of a clinical effect. We know that from the research, that where we see reductions in fear, shift in mindset, building confidence, people tend to get better. And so this gives us confidence in the intervention that the things that we were targeting were actually shifting in these patients. The other important aspect of this trial was the economic evaluation. And we saw that for both the CFT groups, there was a saving at least 5,000 Australian dollars per person per year compared to the usual care arm. So this is like a really large cost savings. And interestingly, this is mainly related to increased participation in paid and unpaid work. So these people were getting back to living again. In terms of satisfaction, these people liked it. So we had an 84% were either satisfied or very satisfied, compared to very low satisfaction in the usual care group. Importantly, this intervention's safe. A lot of people would say, it's dangerous to get people to relax their body and not protect it and re-engage in painful and feared and avoided activities. But we didn't see any increase in adverse events or serious adverse events in the CFT arm over the usual care arm. As I indicated, there was no additional benefit from the movement sensor biofeedback. Now, there are lots of roadblocks to this kind of intervention. Some of these are with clinicians, where we have physiotherapists certainly have traditional roles around their sense of professional identity, training, and they have their own pain beliefs that can become a barrier. 6 months is a significant period of training to really change the behaviors of the clinician and the mindset of the clinician to deliver the intervention. And we also heard that often when a clinician's working this way, if they're not supported in their work environment, that can be really hard. There are often issues around with the patient as well. This approach demands a partnership. It demands a willingness for the patient to take their own journey and to actually take on this process of learning to take responsibility and autonomy, gain autonomy. And so we often, this issue around patients' own beliefs and expectations around care in terms of affordability and access is obviously a major issue. And then we certainly see, this was a tough cohort. And we certainly the clinicians encountered people with, really tough social situations and comorbid health problems where they needed co-care. And this is where we have the problem with the health system, where we have major funding constraints to deliver this kind of care. This kind of intervention takes more time on a session, and often physiotherapists aren't remunerated to spend an hour with a patient in an initial follow-up and half an hour of follow-ups on the follow-up sessions. We have a health system in Australia that will pay for a spinal fusion, but it won't pay for physiotherapy. So time is a major issue within health. And then we have a really siloed healthcare system, which is giving really mixed messages to patients. And then we have societal beliefs around pain, and we have this quite quick fix culture. We want to be, we want quick solutions for complex problems, which we know just don't work. So in summary, we believe we can and must do better for people like Sam. This will involve societal education. It involves the upskilling of clinicians. And this is a huge challenge for us in our group to provide support to upskill clinicians to deliver this kind of intervention. We believe we needed much better integration of care within care systems we don't want to be working in silos, but across care, so that we're providing the same kind of messaging between different professionals. And then we need whole system change. We need new funding models. And of course, we're now engaged in a number of implementation trials to test this intervention in the real world. I mean, this was a pragmatic trial, so it was placed in primary care. But this is being now implemented in a number of different health systems in different countries around the world, which will then capture further data to see whether this is transferable across different jurisdictions. Now, if you're interested in more information about this trial, we have a website. It's called restorebackpain.com. It gives a lot of information on the trial. It describes the training. There are a bunch of patient videos that capture the different journeys that these people have taken. People of a whole variety of ages and social and different circumstances. You also see the access to the infographic there. So I just want to acknowledge the people in this trial. So Peter Kent, my colleague, was the lead author of the Restore trial. We have a wonderful team of collaborators at Curtin University, nationally and internationally. Hello?
Yes, sorry, it took me a bit to get back to the stage. My bad.
No worries. Just wondered if I was talking to myself.
Yeah, no. I wonder that sometimes too, but that's a different story. Okay, Dr. Becker, please state your question.
Thanks for the presentation. Maybe you said it, but the patients in that trial, did they have purely low back pain, or did they have some pain down the legs, any radicular symptoms, things like that?
Yeah, good question. So we included people with back and leg pain. Our exclusions were really primary. We had very few exclusions in this trial. We excluded people with serious pathology, and we excluded people with, progressive neurology, quarter equina syndrome, those kinds of things. But actually, because this is a very chronic group of people, often they had multiple pain areas. Back pain was their primary concern. That often they did report, back and leg pain and other pain areas as well.
Hi, so I know that CFT is currently used to target low back pain, but to me, it looks like a framework that could be applicable for so many different chronic pain conditions. So I wonder what your opinion is on using that framework with other conditions, and if we might see research on CFT and other conditions in the future.
100%. Yeah, you're absolutely spot on. So we really just targeted back pain because it is such a massive issue. We've actually, our team has been conducting studies looking at knee arthritis. So we've got a colleague who's just done a trial, a feasibility trial to take people who've been told they need a knee replacement and to trial this intervention with them. We've done a case series of people with chronic hip pain, where we see this as a framework for managing pain. And, you know, in practice, that's what we do. So whether it's neck pain, shoulder pain, knee pain, elbow pain, it doesn't really matter, because as you say, the factors are not region specific. And so we're had plans to run further trials to test this more generically for pain problems. And certainly what we found with the clinicians we trained in this trial, they were using this not just for chronic pain, but with acute back pain. They were using it for neck pain, shoulder pain. It changed their practice and the way they worked. And you know, the qualitative studies are coming out from this to kind of highlight that.
Follow-up question. Do you think that a framework like this could be used in something like migraine? Because there's a big prevalence of kinesiophobia in that population, and helping them feel safe to move, I think, could be a really important part of treatment.
Yeah, definitely. And it kind of feeds into the question before that around a model for pain. So I work in clinical practice half-time. I see a lot of people who have massive anxiety and fear around triggering a migraine. And we use this kind of process of teaching body relaxation, of graded exposure, of, you know, fear reduction. And that exposure component is just we're seeing more and more, such a powerful learning tool. You know, there's been a lot of, discussion around talk therapy, but actually this is doing therapy. It's what we're seeing from our qualitative work is it's the behavioral experience that has the most potent influence on a patient's shifting their mindset and building confidence. It's those behavioral experiments that we set up that really influence a shift in people that kind of change their trajectory. So we definitely see that around migraine as well.
I have a different question maybe about just availability of the training. So I'm a psychologist who's been working in this sort of field for a little bit here. And I'm really excited about your training. I've been following your research with a lot of interest. And I'm wondering if that's something, that training is going to be moving towards Canada anytime soon or anything like that. Because I actually work with a bunch of physiotherapists, and it would be super primo to be able to bring this to the clinic.
Yeah. So, you know, this is something, as soon as we knew the results of this trial, we've been under siege really from around the world. People saying, how can we access this training? So we're, in fact, the last few weeks, we've just been filming. So we're developing a training platform. We want to develop equitable access to training across the world for people who are interested in this. And we're really interested in developing like a community of practice where we can support. We want to trial a hybrid training model just because of capacity, where we will deliver some online modules, and then the mentoring is the real tricky bit. But we need to build capacity around mentors. But you know, we're really interested in partnering with people on this. You know, it's a area that we're very sensitive to doing in the right way, so that we build clinical communities that can be sustainable. And we're kind of seeing a train the model is the most sustainable way going forward, that we'll train trainers who can support clinical communities to develop this kind of training. So if you're interested in this, lodge your interest on that Restore Back Pain website. And you know, we're also involved in research around integrating this model of care with psychologists. I work closely with psychologists as well. And this model works so well where physiotherapists and psychologists are working together. So yeah, please register your interests on the Restore Back Pain website, and we'd love to reach out to you.
Thank you for that excellent presentation. Out of curiosity, I know you measured pain self-efficacy in your trial, and you identified some benefit with improvement in pain self-efficacy. Do you believe that there may be a cutoff point for intaking a patient with, say, such low pain self-efficacy that they may not benefit, you know, as the tool is intended?
Yeah. So it's a really good question. We're, as you can imagine, with a big trial like this, we've got so many future publications. We're currently doing mediation studies to look at what we see as what are the key ingredients for mediating these effects. Our previous studies indicated that pain self-efficacy is a really key one. We're also looking at moderation studies to go, what are the factors that are associated with poorer recovery? Because, clearly this is not even though we had large clinical effects, there were people in there we couldn't reach. And the qualitative, we've got some qualitative research as well, capturing the journey of people who were responders and non-responders. And this work will give us a real insight into those patients as well. So I can't speak specifically to our data at the moment because this is future work, but we're very, very interested in the people we couldn't reach. And I think one of the things that we've heard from the patients is that it's a real mindset shift around their role in healthcare, where often, patients feel passive recipients of care, which just disempowers them. But actually this different role of the clinician being a coach, as they come to that position of where they actually want to participate in a different journey. And of course, not everyone wants to do that. And so this is where our implementation research will be very interesting to kind of look at, real world implementation, this as a model of care, to see what the engagement will be, because that can be so tricky when someone's just caught in that downward spiral of dependency, to get them to take that next shift towards taking on a partnership where they start taking control. But it is very values driven, so it's really orientated around the values of the things that people want to get back, which I think is a huge motivator for this approach.
Hi, Peter. Thanks for your presentation. I've been following your work for a couple of years, and I'm curious about, I just have a slightly technical question. Something that comes up in clinic work with exercise rehab often for me is working with folks who have mental health diagnoses that are quite active in terms of working with military veterans who have chronic pain, and helping them to remap somatosensory aspects of movement, and just with the intense amount of dissociation that is a real necessary coping strategy. Did you have any feedback on something like that in terms of how this approach might work?
Yeah, so it's a really good question. Look, we know from the clinicians who are in the trial, they worked a lot with people who had history of trauma, and that's a really delicate area. And this is where we're kind of branching our work towards developing models of co-care, where we see that this work works so well in tandem with psychologists who are working in partnership with the physiotherapist to work with people. But this idea of the disconnection of the body, the embodiment of pain, is so interesting. Such an really interesting area of work, is that we're bringing people become super vigilant on the pain, but avoidant of their body or disconnected from their body. And you heard that with Sam's story, of this almost a disconnect between pain and this kind of clenching of the body and this, this sense of panic. And we often see that around trauma, where people lose a connection with their body. And so we're bringing them back to their body, which can be very threatening. But obviously, it may re-emerge trauma. And so obviously we've got to be sensitive to that. But that's a part of that journey for them, is to realize actually there is safety in their body, that they can reconnect with their body. They can have a different sense of trust in their body, an ability to relax their body and not respond to pain by panic and clenching and fear and avoidance. And so that's where we see this crossover between the embodiment of pain and trauma, of that the journey that this seems to take people through can, deeply impact on those areas. We just have to be very sensitive to how we manage it, and then, obviously get psychological support when people start unraveling, so that we can take them through that process.
No, thank you, Peter. That was a really thought-provoking presentation, and we are certainly very willing to be the next site for to participate in
Huh.
your training.
Go. Well, I'm sorry I can't be there in person. I'm a Kiwi by origin. I love Canada. Last time I was in Canada, I broke my arm skiing.
Oh.
Trying to race my daughter down a ski slope.
Right. So it might be time to reduce that fear and come out and ski
I have no
again.
fear. Don't worry. I carried on.
We know you
skiing
can do
15
it.
days with a broken arm, so I wasn't fearful at all. I just didn't know it was broken.
Oh, I see. Okay. All right. Well, please join me in thanking Peter O Sullivan for the wonderful presentation.
Thank you.
Thanks. Pleasure. Take care. Bye.
Have a good rest of your weekend. Again, I know it's early, so thank you so much.
No, I'm actually off for a bike ride now, so I've been texting my friends to say, sorry, I'm running late.
Well, indeed, then enjoy. Is it a sunny day there?
Yeah, beautiful day. Yeah.
Wunderbar. That's excellent. Thank you so much, and look forward
Pleasure.
to keeping in touch.
Okay, bye.
Bye.